happened to this gentleman is he was riding a horse. This is called a T-post in America. It's a fence piece that holds the fence line. Now they're capped for this particular purpose. But he fell off the horse, landed on it, and EMS came in, sawed it, kept it in place, which is the right thing to do, and then brought him into this lateral position. Multiple reasons why, I won't get into it, but he came, passed medical history, no drugs, great. I'm a pharmacist, also one of my trades, and hypertension, diabetic, and sleep apnea. Okay, so when you look at this scenario and you get these vitals running from the emergency medical system, obviously there's a lot of things going on in your mind. He's hypotensive-ish, borderline. He's starting to get tachycardic. What I look at is his SpO2 is 90%. And we know that the oxygen dissociation curve, he's coming down, right? So, and he's already on a non-rebreather. So we're hitting that well. And he's alert-oriented, but he's groggy. So I have no advanced airway yet at this point, but he is groggy, and that could be from the EMS giving him some narcotics, maybe some anxiolytic meds. And then we addressed his blood sugar because he was a diabetic, just to make sure that that's not incorporating his neurostatus. So next slide. So when you're looking at this, you're thinking, okay, this guy definitely has a difficult airway. And reason being is because he has no movement of his axial occipital joint, right? And that's something, one of our techniques is do sniffing. I can't do that. The reason, he's laying on his left side. Now that's a con and a pro. And the reason being that it is a con is because obviously, if I'm thinking about an LMA, in my experience, LMAs don't seat well when they're in the lateral position. And so I'm like, well, I could use it to advance another airway in there, but if I get in trouble and I have to bag him with the LMA, it's going to be a problem. And if you have an entry and you're looking at all that time consumption, it's not going to be favorable for me. So I already removed that from my equation in my mapping. The other positive, though, is that he is on his left side. And if you think about intubating, you're coming in, you're sweeping the tongue to the left, because you're intubating typically with your left hand. And so I take that as a positive. It's a win. I'll take what I can get. So we'll move on. We'll address this later on what we did, but let's continue. So next slide, please. This is where you guys need your phones. So after that slight definition, experienced provider and difficult airway, one that you went in, you had to use another source, or you found it to be hard to ventilate. Yes or no? And hopefully, if you hit this little button right here, they'll come up. I didn't want any, I wanted blinded bias, but we'll for hasteness, we'll go. So I got 7 people, 8. You see that? Sweet. All right. So that's encouraging. I think if you don't experience it, you're relying on your training, your skills. And I'll tell you, superior judgment always trumps superior skills. But that means that if you know you don't have it, or you call a friend. This is not about us. When we deal with this stuff, it's about that person that's on that table, right? And so we want to advance that person's life, and I think it's great. I'm grateful that everybody's here. We'll go to the next slide. All right. Next one is going to be this cricothyrotomy. Now, this is part of that whole vortex that we had talked about. I think it was Dr. Jamie, right, that brought the vortex into place. So the cricothyrotomy is one of those pieces. Has anybody ever performed one? No. And you can hit, again, this little I button here, if you wouldn't mind. And I would assume that's the case. Most people don't reach for it. That's fine. We can just stay on the slide. I'm assuming that most equipment. This is actually selfish of me. I would like to know what equipment most people have in regards to the toolkit. And when I say equipment, I want to be readily available. So in your department. And more or less, it is selfish of me, but it's more or less also an indication for you to be like, what do I need in my cart? Do I know the equipment in my cart, and can I use the equipment in my cart? Particularly when I have a difficult airway. Because when you pull it out at the time of when the airway happens, it's not the time to be looking at it and saying, how do I use this cric kit? Do I use the needle? Do I use the scalpel? If I go to the needle, how do I attach something to that so that I can bag the person? That is not the time. What would be the time would be, I need to find out somebody in this department that knows how to do our kit, right? That's good. All right, we'll move on. It looks like stuff. Okay, and this is cool. How many people have used it for advanced airway? Looking at even post-operatively. What I'll be talking about today is how to understand that you're in the right place. And then how do I know that's true? And we'll talk a little bit about Crike stuff. I wish I put percentages. Looks like we have. All right. So let's talk about the components. And I'm going to briefly touch on this because I really want to keep everybody on, excited about this. Our responsibilities is to recognize a potential problem. That's what we're trained to do, right? When we saw that difficult airway, everybody was probably like, man, that's a difficult airway. I don't want to be there. Or I like to be there. I want to see how it's done. But you recognize the potential problem. What you do with that problem and how you itemize your skill set, the strategy of mapping, that's the important part. You could be the best person to do a finger intubation in the world. But if it didn't apply to the situation and you try it, you've now succumbed to this turmoil. Does that make sense? Yes, no? Okay. So the strategy to overcome the problem is going to be primarily what your skill set is and what you know you have available to you. And that could be other people. That you could be the person that's like, hey, look, tap out, I'm not going to handle this. And I think that's perfectly acceptable. That's a wise person to say that. Because that strategy, your judgment trumped your skill set, if you know what I mean. So we'll move forward. And if you don't do cricothyrotomies on a routine basis, practice. Like, I would say anybody that has done it probably has done it once in this room. And if you don't do it often or never before, get out something that helps you practice. Like in my mind, I already tell you what side of the bed I'm going to stand on and then how I'm going to cut. I can detail that out to you because I think about it all the time. And then that way when I'm there, I can help. And that's where we want to be. So this is called skill decay. This was put out actually by, I think, the American, this. So this is called a strategy. So have a strategy. You have a plan, and then you have another plan. And I can tell you, if you say, hey, my first plan, I'm a clinical and a associate professor at a university in the United States, and I had a student, and I'd be like, you know what, that guy's turning blue, I probably should do something. And you're like, yeah, here, take this, look at it. Where do you want to start? I'm like, I don't know, in the middle maybe? So I would say that this is probably not safety foundation. That's what it is. So they take an American's ASA stuff and a negotiation plan. And so they have their own. Go ahead to the next. This is actually what was presented earlier, and I do like it for the simplicity of it. Actually, the tragedy of this, why this was